I'm Juha. This is Mario. We're going to be moderating the session. This is the Funderburg Symposium, Tackling Gastric Premalignant Lesions, Insights, Uncertainties, and Practical Strategies. We have an excellent lineup of speakers today. I'll go ahead and kick it off and introduce our first speaker, who needs zero introduction at all. She's written about every paper that we're going to be talking about today. But it's my great friend and colleague, Shalja Shah, who is here at UCSD, and she will be talking on targeted gastric cancer screening in the U.S. Act now or wait for more data. Welcome.
Thank you. Wonderful. Thank you so much. This is the symposium that I've been really just looking forward to the entire conference. So it's great to be here among friends, colleagues, and definitely look forward to the discussions. Again, thank you for the invitation to the course organizers. I'll be speaking on targeted gastric cancer screening in the U.S. Act now or await more data. And I'll say from the outset that I am of the strong mindset, I can imagine many of you are here in the room, that we should act now, but in parallel generate more robust data and lay a foundation for high quality screening. These are my disclosures. And so gastric cancer, as we know, remains a major global health problem, and it's still the fifth most common cancer and the fifth leading cause of cancer mortality. And on our current trajectory, if we are to do nothing, which is the black line, we can expect a 62% rise in gastric cancer cases and fatalities by 2040, considering also the aging population. But as we know, and as you can see in this heat map that we've seen several times already at this conference, gastric cancer risk varies according to the country of origin. But what's not appreciated in this map are those countries of mixed origin. And a lot of this, most of it, reflects the fact that immigrants from high incidence countries retain their risk of gastric cancer incidence and mortality upon immigration to lower incidence countries like the United States with high population diversity. And so to illustrate this is a population-based analysis from the California Cancer Registry that quantifies the burden of gastric cancer in the 10 most populous racial and ethnic groups in the United States, including disaggregated Asian Americans by country of origin. And we looked specifically at a screening age population. And so you can see very clearly in that purple box that the incidence of non-cardiac gastric cancer compared to non-Hispanic whites is anywhere from 2 to over 13-fold higher in all non-white groups. And in some groups, especially Korean Americans, the risk of gastric cancer approaches that of colorectal cancer. And be aware that the majority of gastric cancer cases in the United States are diagnosed in the advanced stage. So what we're seeing in these registry data likely is an underestimate of the true burden of gastric cancer. And so the reason we must act now is that immigrants account for 30% of the United States population, and nearly all of these immigrants are from countries of high gastric cancer incidence. And so as I mentioned, they retain their risk even upon immigration to the United States. And according to the Pew Research Center, immigrants from high incidence countries are expected to account for 90% of the population growth through 2065 in the US. And so our high-risk population in the US is only going to continue to grow. And this line graph compares the proportion of gastric cancers diagnosed as early stage cancers, which, as you know, is the stage of cancer where resection, either surgical or endoscopic, is curative and is associated with over 98% 5-year survival. So to orient you, the green line shows the impact of gastric cancer screening in South Korea, where after the initiation of screening in 2002, the proportion of early stage cancers steadily increased to now over 70%. And these are data from 2016, so it's likely even higher. And you can see the United States, which is that red line, is just a complete flat line, 24%. And this is reflected in those 5-year survivals that I've highlighted below. So in the United States, 5-year survival for gastric cancer, 36%. And in South Korea, it's now 72% and actually higher now, past 2016. And so interestingly, gastric cancer screening in Japan and South Korea on a population level was implemented without effectiveness studies and was solely based on knowing that there is a high incidence of disease, high mortality, and that early detection saves lives. Now, of course, we do have evidence in the form of cohort studies, so robust observational data, including this meta-analysis of over 340,000 Asian individuals that compared endoscopic screening versus no screening, and demonstrated that endoscopic screening was associated with a 40% reduced risk of gastric cancer-related mortality. But in this meta-analysis, there was actually no reduction in gastric cancer incidence, again, driving home that point that where you save lives is through early detection and that opportunity for curative resection. So there's no studies of screening versus no screening in Western countries with mixed incidence populations like the United States. However, this was a recently published study, so it's a community-based randomized controlled trial of nearly 235,000 people that was recently published in Gastroenterology. And the study evaluated the effect of endoscopic screening versus no screening on upper GI cancer mortality in a universally high-risk region compared to a high-risk group within a lower-risk region in China. And so there's many considerations in the study, including how they actually defined their high-risk group within that lower-risk region. It's a great Journal Club article if anybody's looking for one. But it is actually the first randomized controlled trial, at least showing the potential impact of risk-based screening in a mixed incidence population. So in this study, if you just look actually at the, because people are randomized based on the invitation to screening, but if you looked at the per protocol analysis, which included only individuals who actually underwent endoscopy for screening, that screening high-risk individuals in a non-high-risk region was associated with a 50% reduction in gastric cancer mortality. So there's no reduction in esophageal cancer, but if you look actually at gastric cancer, there was reduced mortality. And so what about the United States? So we don't have any clinical trial data, but in addition to the indirect evidence from these non-US studies and the epidemiological data that I presented already, we actually do have additional indirect data in the form of simulation studies and modeling studies. So this is a study that we conducted a few years ago evaluating the cost effectiveness of risk-based endoscopic screening for gastric cancer in the US. And we selected race and ethnicity as a surrogate marker of risk based on the epidemiological data that we have, which I presented at the start of the talk. And ultimately what we found was that EGD at the time of colonoscopy for colorectal cancer screening with ongoing surveillance if intestinal metaplasia was diagnosed was cost-effective for Asian, Hispanic, and Black Americans, but not for non-Hispanic whites universally. And the major driver here, again, for that cost saving was that opportunity to diagnose an early stage cancer and offer the ability of cure. And we also ran several one-way sensitivity analyses to identify certain thresholds above or below which the model is no longer cost-effective. And the model was sensitive to the baseline prevalence of intestinal metaplasia, as well as the progression rate of intestinal metaplasia to dysplasia to cancer. And understanding these baseline rates is helpful when we want to try to generalize the model to what we have in terms of real-world data. And for intestinal metaplasia specifically, so focusing on that, 8 to 10% in our study seemed to be the cutoff. So if the prevalence of intestinal metaplasia was higher than 8 to 10%, then it's more likely screening would be cost effective. And so let's look at some US data. So this is a retrospective study from Seattle that evaluated 2,000 patients who had gastric biopsies between 1999 to 2014. And the prevalence of intestinal metaplasia in Asian, Black, and Hispanic individuals 50 or older was 20 to 50%. And another prospective study from Kaiser, which was done among individuals with a family history of gastric cancer who underwent EGD, the majority of whom were Asian or Hispanic, found that there's a 44% prevalence of intestinal metaplasia, with most of these actually extensive intestinal metaplasia, so 78%, so high risk. So based on these data, it's very clear that the current estimates of intestinal metaplasia in easily identifiable high-risk populations far exceed that 8 to 10% threshold. So again, we must act now. And so it's extremely exciting because based on these and other data, it has culminated in the past few months into 2 guidance documents from the ACG and AGA for risk-based primary and secondary prevention for gastric cancer. So this is the recently published AGA Clinical Practice Update, or CPU. And so CPUs can be thought of as the little sister to the guidelines for topics of high clinical relevance, but where the level of evidence doesn't necessarily lend itself to a formal grade process. And so the first best practice advice statement here is focused on identifying those high-risk groups in the United States who might benefit from endoscopic screening, whereas the second BPA is really identifying that endoscopy is the best screening test. And so you can see here that individuals for whom we should consider endoscopic screening, early generation immigrants from moderate to high incidence regions, which we've defined here as greater than 10 to 12 per 100,000, family history of gastric cancer, non-white racial and ethnic groups with established moderate to high incidence of gastric cancer. And here we do acknowledge that race and ethnicity are surrogate markers and really pushing for biological constructs for risk stratification. Personal history of chronic H. pylori infection with additional risk factors, and certain hereditary GI syndromes. And BPA-4 was focused on identifying the critical importance of primary prevention through H. pylori eradication, but really emphasizing that this alone is insufficient because we know that gastric precancerous conditions can progress despite H. pylori eradication. And then these are the ACG guidelines, which did undergo a formal grade evaluation of the evidence. And so you can see in that first one, so suggesting against routine screening with upper endoscopy for the general population, which I think we can all agree. But the second one, so this was, hopefully we can talk about this in the discussion, but this was, there was a lot of back and forth that we can certainly talk about, but ultimately, because of the level of evidence, that there is insufficient direct evidence. And so ultimately, we cannot make a recommendation on opportunistic screening for gastric cancer and GPMC with upper endoscopy. Again, just due to that lack of direct evidence. But we did, again, so acknowledging though, so this was, again, a lot of back and forth, but really to still acknowledge that even though there is not direct evidence, that should not be taken as compelling evidence that we should not do anything right now. And so ultimately offered a key concept that endoscopic screening should be considered in people with family history of gastric cancer on an individualized basis, and offered the age of 45 to 60 or 10 years before the diagnosis of gastric cancer in the youngest affected family member, and also acknowledging first-generation immigrants from high-incidence countries as also populations that warrant screening. And so while it's an exciting time with substantial progress made in the US supporting an Act Now approach, it's absolutely critical to recognize that the actual impact on mortality are going to depend on essentially 2 things. So uptake by the intended population, as well as our ability to not miss lesions, since we know that early detection of gastric cancer is what is driving that mortality benefit. And so you can see here in this image really how subtle, I don't know if this shows up, but you can see in that lower image how subtle there's an early gastric cancer that is there. And so this will be a nice segue to Dr. Lee's talk. So in conclusion, really we must act now. I don't think there's any way around that we do have to act now. There are identifiable populations in the United States at substantially higher risk for gastric cancer, which are increasing, as I showed. That said, we do need a more precise biological understanding of risk factors for gastric cancer and progression to intestinal metaplasia and gastric cancer, and ideally move away from race and ethnicity-based stratification. Non-invasive, ideally, biomarkers as well as tissue-based biomarkers would also be very helpful for, again, better defining that high-risk population. We know that gastric cancer is preventable through primary and secondary prevention, and we now have guidelines and consensus statements for high-risk populations. And that is, again, based on strong direct evidence from non-US studies as well as indirect US data. But we do need to, as we discussed in the morning, really standardizing and improving H. pylori screening and eradication practices, so primary prevention, improving adjunctive technology and training to improve detection, which Dr. Lee will walk us through, attention to implementation and addressing the patient level and systems level barriers to screening uptake. And this is where we can take a lot of lessons from the colorectal cancer screening experience, and especially understanding that gastric cancer is impacting a different population where there really are special considerations in terms of language barriers and other aspects. Cost, resource efficient modalities, an expanded pool of Western providers to perform endoscopic resection, as well as, of course, prospective trials. And with that, I will conclude. Thank you so much.
So we move to the second speaker, and now how to optimize gastric intestinal metaplasia surveillance. And I don't think we need also presentations. Dr. Don Lee, coming also from California, actually, yeah.
California. Thank you, Mario. Thank you, Juha. So it's a great pleasure to be here. I think it's a great session because it covers a spectrum of the pre-cancerous gastric conditions. I'm going to be talking about GIM surveillance. So I'd like to start this talk and put this GIM in the context of the multi-step process of gastric cancer pathogenesis. This is what we all know as Korea cascade. And you can see that intestinal metaplasia is an essential step in this whole process. It basically is a pre-malignant condition and characterized by the replacement of normal gastric epithelium with epithelium that resembles either intestinal epithelium or even colonic epithelium. The two subtypes, complete subtype and incomplete subtype. And essentially, GIM is adaptive response to chronic injury, especially after the chronic H. pylori infection. GIM on endoscopy can appear as multiple, like focal nodularity in the mucosa involving the antrum or incisura, or it can be multinodular or multifocal area in GIM involving the larger area of antrum, or extend to the corpus or body, which we call extensive GIM. And this map showed you the incidence of gastric cancer in the world. You can see that gastric cancer is more common in East Asia and in Eastern Europe, and also the Mesoamerica and mountains area of South America. And this study, I think by Monica and Doko group, and they investigate the prevalence of GIM in different countries. They showed that there's a strong prevalence of GIM, and correlation prevalence GIM with the local gastric cancer incidence. For example, GIM is more prevalent in countries with high gastric cancer incidence and less prevalent in countries with low gastric cancer incidence. And the same study also showed that GIM is more common in people with H. pylori infection, irrespective of the gastric cancer incidence in that country. In the U.S., we have a very diverse population here, so there's the prevalent GIM varies widely in different subpopulations in the U.S. For example, the upper part of the slide showed you that this study investigated the prevalent GIM in different U.S. population based on race and ethnicity, and showed that, for example, Korean Americans has much higher prevalence GIM compared to, say, Asian Indian Americans. In the lower right part of the slide, you can see there is another study which investigated the prevalence GIM in immigrants in the U.S. based on their country of birth. Interestingly, you can see that there's a high variation in GIM prevalence. People who were born in Ecuador had much higher prevalence of GIM compared to people who were born in Puerto Rico. But overall, in the U.S., GIM is more prevalent in people who are first-generation immigrants from high gastric cancer incident regions, non-white races or Hispanic ethnicity, and those with chronic H. pylori infection. So how fast can GIM progress? Based on the meta-analysis, you can see that the cumulative incidence of gastric cancer in patients with GIM at 10 years is about 1.6%. This is concordant with another study from Sweden. That study used the national database from Sweden, which showed that 1 in 39 individuals with GIM, which is about 2.6%, will develop gastric cancer in 20 years. So now we know that there are several risk factors that predict the high risk of gastric cancer from patient in patient with GIM. As those include extensive GIM, incomplete subtype, or those with a family history of gastric cancer in the first-degree relatives. Those factors, if present, confers a higher risk, I would say from 2-fold to 5-fold higher risk of gastric cancer. And I do want to mention this organ OGM system because these two systems are widely used in Europe, Asia, and South America, but not in the US. But these two systems are validated and very useful in predicting risk. You can see from here that the people with OGM 3-4 disease had much higher risk of gastric cancer from GIM compared to OGA 1 and 2 disease. And this is another interesting study by Monica Laskowska's group. They investigated the progression rate from GIM to gastric cancer in different countries with varying gastric cancer incidence. They found that once GIM is diagnosed, the progression rate from GIM to gastric cancer actually was similar between the low gastric cancer incidence countries and high gastric incidence countries. And this, along with other studies, suggests that once GIM is established, race, ethnicity, and geographic location are not independent predictors of progression from GIM. This also provides some rationale to have a kind of unified approach to surveillance GIM from different countries, irrespective of the country of origin or race or ethnicity. So can GIM regress? This was a study in China. It's Shandong intervention trial. You can see that there's among people with GIM, there's a histologic regression after atypical treatment versus placebo. And based on this meta-analysis, it shows that GIM can regress in up to 30% people at 1 year, in 26% people at 3 years. But you have to be careful because the most of the study on regression of GIM were of very low quality evidence and subject to high risk of bias, especially sampling bias. If you take biopsy not from the same area GIM, and on second endoscopy, you will get a conclusion of regression, which is not the case. But I do want to mention this high-quality study from Singapore. It's a GSEP study, very interesting. So they actually stratify patients by their baseline OGM score. You can see then they follow patients at year 3 and year 5 with surveillance endoscopy with biopsies. And then you can see from here that the people who are in the low-risk OGM status, the OGM 1 at baseline, it's very uncommon for people to progress to a higher level pathology on follow-up. In addition, about a quarter of patients in this group actually had reversal of histology to normal histology with no GIM. And in contrast, people with the high OGM score 3-4 at baseline, then majority of people will stay in the high risk category during follow-up, and there's no reversal of histology observed in this group. And in fact, people with high OGM score 3-4, and even OGM 2, had much higher risk of progression of gastric cancer based on this study. This already provides support to have this more intensive surveillance in people with advanced stage GIM. So this is all the knowledge we have about GIM, but we still face a lot of challenges and gaps in knowledge. For example, we have an incomplete understanding of factors that drive progression of GIM to gastric cancer. So that's why we don't have a precision method to predict the risk of gastric cancer in people with GIM. And that's a big knowledge gap. And also, we don't have a reliable biomarker, as Xiaojie has already mentioned, to predict GIM progression. We still need endoscopy, which is invasive, and with histology to help re-stratify those patients. And another gap in practice is that in endoscopy in the US are not really trained sufficiently to diagnose GIM, and people do not want to use the imaging enhanced technology such as NBI or LCI when they evaluate GIM. There's still like inconsistent gastric mucosal sampling, for example. We don't always follow the single biopsy protocol. We put all the specimens in one jar without specifying is from antrum or corpus, and people are reluctant to take additional targeted biopsies for GIM. So those lead to missed GIM lesions and understaging of disease. And lastly, we have a limitation in pathology reporting. So, for example, GIM sometimes is not available in the US routinely. We don't have OGA OGM system in this country. So we have a very limited histology information to inform risk stratification. So as Shorter mentioned, we have three guidelines or recommendations from NGA, from ACG, and from ESGE. And so I won't go into details of these guidelines, but in general, they're very consistent in terms of the surveillance plan for GIM. So they all recommend that for high-risk GIM patients, you should do intensive surveillance, and for people with low-risk GIM, perhaps low intensity or even no surveillance. So at the end of the day, how do you triage a patient with new diagnosed GIM? And here's the suggest algorithm primarily based on ACG and AGA recommendations. So first of all, you want to screen and treat for H. pylori and confirm the eradication if positive and after treatment. And then you really want to re-stratify this patient. Does the patient have high risk or low risk of GIM? I mean low risk by if they have only focal GIM involving antrum only and with no other risk factors, then this patient has a very low risk of gastric cancer in the future. So this patient may not need any further surveillance endoscopy. But if you're not sure about your quality, you want to make sure there's no progression, you're concerned about the whether you did a thorough job in the first exam, you may want to bring the patient back 3 years or less just to recheck, make sure there's no progression. So the second endoscopy, if to confirm low risk findings, then patient probably does not need any surveillance. But conversely, if you find something high risk, then you bring patient back another 3 years or sooner, as indicated. Then if patient has high risk GIM, meaning that there's high risk GIM histology, meaning his extensive GIM with both antrum and corpus involved, or there's incomplete GIM subtype if your pathology agree to do it for you, or if you have availability of OGM or ORGA score 3 to 4 disease, then patients are high risk GIM, or patient belongs to the high risk population. For example, patient is a first generation immigrant from a high gastric cancer incident region, or there's a family history of gastric cancer in the first degree relatives, or patient belongs to the high risk racial and ethnic groups such as Asian or Black or Hispanic groups. Then you bring your patient is considered as high risk individual with GIM. In that situation, you would probably bring patient back in 3 years or sooner if multiple risk factor present, or you are not sure about your quality of endoscopy. So in summary, GIM is a pre-malignant condition with marked variation in prevalence based on geographic locations, risk, and ethnicity, and H. pylori infection status. Patient with extensive GIM, incomplete subtype, OGA, OGM, 3 to 4 disease, or with a family history of gastric cancer in the first degree relatives have a higher risk of gastric cancer and should receive close endoscopic surveillance. Mild GIM may regress, particularly after H. pylori treatment, but advanced GIM may continue to progress, which is the so-called point of no return. And lastly, precision methods for GIM restratification remain lacking and should be the focus of future research. Thank you for your attention.
I hate to start this because Greg told me he changed the title of the talk. And so the next speaker is Dr. Gregory Lowers from Moffitt Cancer Center, and he will be speaking to us on tackling gastric premalignant lesions, insights, uncertainties, and practical strategies. Welcome.
Thank you. Thank you very much for the invitation. So being the pathologist, I'm the odd man's out, but we'll take on the challenge, and those are my disclosure. Obviously, it's not a surprise to anyone in the audience that the majority of non-syndromic gastric cancer are related to Helicobacter pylori infection, and that this long-standing inflammation that starts 20 or 30 years before development of a precancerous lesion will lead to different stages. Multifocal atrophic gastritis, intestinal metaplasia, and dysplasia, which can be divided in early precursor lesions and late precursor lesion. You're all aware of those cumulative rates of incident gastric cancer associated with multifocal atrophic gastritis and intestinal metaplasia, which also obviously have led to the detection strategies which have been developed, and the same thing for dysplasia. All the clinical societies have developed and over time updated various guidelines and technical reviews and CPUs, and obviously from Europe the US, or even a recent review in gut was looking at the similarity and dissimilarity in some cases in the strategies from different societies, even outside Europe and the United States. But the backbone of all the strategies are in the recognition of intestinal metaplasia, the extent, the grade, and for intestinal metaplasia, the histologic subtype. That's where the pathologist should play an important role. So what are those early precursor lesions? First of all, the first stage is mucosal atrophy. And if you go back to the original paper of Pelayo Correa, mucosal atrophy is not only the replacement of the mucosa by fibrosis, as identified right here, and this is an example of normal antrum, but it can have another stage, an integrated metaplastic changes, which will be associated as well. However, intestinal metaplasia, if the mucosa is antral or antralized, or even the presence of pseudopyloric metaplasia, which is not uniquely but frequently associated with autoimmune gastritis. Obviously, the prevalence of intestinal metaplasia is very focused only on the Caucasian, and we know that obviously this is quite different for the immigrant population. Based on this, there's been significant amount of work, in part led by people like Massimo Rugge, who developed this staging system of the Olga system. And if you look at this original paper again, it is a global system that not only look at the presence of atrophy, meaning the loss of glands, but also the possibility of metaplastic changes associated with this. We went already through this table, which is known by all of you. And in order to get to these different stages, the pathologist is supposed to evaluate by the amounts of atrophy and metaplastic changes by a level of 30% or so. And eventually for each fragment to calculate an average. What was shown some years ago now is the certain degree of, or limitation rather, in the inter-observer variability of the Olga system, mostly, as you can see, in the middle part of a staging system. However, if you go back to this original paper, they looked at a very strict definition of the Olga, just limited to the loss of glands, but not the metaplastic changes that can be associated. All this being said, and in this other study done in Colombia, you can see that the Olga has the worst level of inter-observer variability between different observers. This one was with the trainee, and you can see the trainee was doing a little bit worse than the attendees, but not much worse. On the contrary, intestinal metaplasia for different group or pair rather of observer had a high level or a better level of inter-observer variability. So that led to the development of the OLG system, where the idea was just to replace atrophy by just recognition of intestinal metaplasia using the same scoring system and developing an average, and obviously coming up with the same different stages. The same studies demonstrated that this time the inter-observer variability was better throughout the different stages, although again in stage 2 it was not optimal. So this is what the pathologist can or should do in practice. This patient obviously had a good sampling of multiple biopsies. Then you evaluate the amount of intestinal metaplasia, you run an average, and eventually you get a score. All being said, it has been shown that the OLGIM is somewhat less sensitive than the OLGA system, focusing only on the presence of a metaplastic process. In these studies looking at over 4,000 individuals, you can see that there was a risk of downgrading the OLGA about 6%, with 2 of 67 incident neoplastic lesions that were at missed or actually only limited to a low-grade Olgim. So a less sensitivity way to look at the atrophy and changes of the mucosa. So it's not only the extent, obviously, of the atrophy, but also the quality of the morphologic changes. And we discussed that very briefly already. We look at the complete and incomplete intestinal metaplasia, and the diagnostic criteria have been published 30 years ago by Pelayo, Correa, and others. And you have two groups: complete intestinal metaplasia and incomplete intestinal metaplasia, where morphologic features are quite characteristic, and I won't bore you with those findings. Obviously, it was pointed before that the recognition of incomplete metaplasia has significant consequences in terms of the risk of those individuals. But what is also important is to recognize that a fair amount of those individuals are either an incomplete type 2 or, which is more practically, a use of a mixed phenotype. How can we get to a better classification? First of all, the iron diamine Alcian blue cannot be used anymore because of safety issues in the laboratories. So we can use the Alcian blue PS. All this being said, the special stains are not mandatory nor needed. Actually, the subclassification of intestinal metaplasia was developed way before Dr. Jazz and Philippe had developed their histochemical staining papers in the 1980s. The morphologic features are also characteristic. And just to show you, we published last year a series of 9 international GI pathologists looking at a series from Austria. And what we demonstrated is that not only for the presence of intestinal metaplasia proper, but even in the subclassification, we had a satisfactory kappa value, meaning that with some training, you can do the work. An important feature is also in that series, you can recognize that 28% of those individuals had mixed, 17% had mixed phenotype with a predominantly incomplete, which is an area that may need increased evaluation. And the reason for that is because incomplete IM or predominantly incomplete IM is associated with a higher hazard ratio of developing gastric cancer. So reporting Olga and Olgin should be targeted. What we see frequently in the US is that it is not a substitute for an histologic diagnosis. You're supposed to do Olga and Olgin in the setting of patients which are with Helicobacter pylori or autoimmune gastritis at risk of gastric cancer. Number two, atrophy is not uncommon in aging mucosa, irrelevant even outside of people treated, people with Helicobacter pylori infection. The presence of IM does not imply a diagnosis of atrophy, and you have opportunistic mild intestinal metaplasia can be observed in reactive gastropathy, about 20% of the patients, eosinophilic gastritis, 10-12%, non-Helicobacter pylori gastritis, individuals that should not receive the same Olga or Olgin staging. And obviously, what we need is to engage the community, including the pathologist, and most particularly, I think, in the IM subtyping, and we may discuss that later. So the second part of my talk will be on the more advanced preneoplastic processes, which is obviously dysplasia. And dysplasia, as you all know, is mostly associated with type 2 or type 3 Olga, stage rather. And we classify them in low grade and high grade based not only on the architecture, but also on the cytologic features, with criteria which have been quite well established. However, this is a long, vexing problem of inter-observer variation, not only for stomach, for Barrett's, or for in the setting of inflammatory bowel disease. There is only fair to moderate agreement. We have good results when it's benign versus high grade, but really a poor agreement when it comes to indeterminate versus low grade dysplasia. However, I always make the point is that we try to put this in boxes, but dysplasia is a biologic process, so there is a continuum which is not always easy to quantify or qualify. We always go back to this terrible paper of 1993, where between general pathologists and GI pathologists, you can see there was a downgrading of 51% of the cases. I think this is past, this is an old story, but it's still there, and I think it's important to remember that between general pathologists and GI pathologists, there is some variability. Why is there variability? Well, again, because the biologic features of dysplasia versus regenerative atypia can have significant overlap, whether you're looking at erosive gastritis, reactive gastropathy, or ever non-conventional foveolar dysplasia, for which not all pathologists may be fully aware. That leads sometimes to a diagnosis of indefinite for dysplasia, and that doesn't mean that your pathologist is indefinite. That just means that it is difficult to really corner the biologic nature of the lesions, that they look based on the cytologic and architectural features, and means only that these patients should be followed more closely. What does that mean when you review those cases? There was a very nice paper from Australia some years back looking at the revised diagnosis of 47 cases of indefinite for dysplasia, and you can see that 53% of them remain indefinite, a quarter or so, a little bit less, became negative. There were still some that were upgraded to low-grade dysplasia, and even 2 to high-grade dysplasia, even reviewed by a GI pathologist. This is important to realize that even when cases are quantified as and characterized finally as indefinite for dysplasia in the same series, 11 cases were followed for about 2.4 years, and you can see that there was still progression to ever cancer in 2 of them, and low-grade dysplasia in 1 of them. So even patients with low-grade dysplasia need appropriate follow-up. What are the opportunities to improve the diagnosis of dysplasia? Better sampling, and obviously this is from another type of literature looking at the biopsy versus endoscopic mucosal resection, but obviously more tissue equal better diagnosis. You know, the pathologists always want more. And you can see that 23% of those cases were high-graded, 15% as cancer, and 2 as chronic, came down back as chronic gastritis. We have to take into account the background, obviously not only interstitial metaplasia atrophy, but also erosion, acute inflammation, and medication. Importance of interdepartmental consensus conferences. Talk to your pathologist, and your pathologist should talk to you, and if needed, you can call on a GI pathologist. So what are the practical strategies? Evaluate the context, obviously. Appropriate appreciation of histopathologic subtleties. Engagement of pathologists. Education. Distribute the clinical guidelines. I can tell you that many of my colleagues have never seen those papers from Gastro or from ACG or from Europe, even the European studies. Communicate with them and get them involved in patients' management. Thank you.
So we move now from the sporadic field to 3 topics, more specific topics. Hereditary diffuse gastric cancer, and also we move again to Europe. Massimiliano Di Pietro from Cambridge. Thank you, Massi.
Thanks to the AJ for this kind introduction and the moderators for the introduction as well. I'm going to focus on hereditary diffuse gastric cancer, paradigms for management. Dr. Laskowska has given a very comprehensive lecture on this topic yesterday. So I'm going to focus a little bit on the recent evidence from our research and how this is hopefully going to change the management of this group of patients. Just as an introduction, so hereditary diffuse gastric cancer is an autosomal dominant syndrome which is associated with an increased risk of diffuse gastric cancer and lobular breast cancer. Typically associated with pathogenic variants of CDH1, although recently also ctNNA1 has been associated to this syndrome. And the definitive treatment for this syndrome is prophylactic total gastrectomy, given the high risk of gastric cancer. So this is the recommendation from the most recent guidelines published in 2020, according to which if you get a diagnosis of CDH1 pathogenic variant, there is a recommendation for prophylactic total gastrectomy. If in combination with patient's decision, a decision for delaying gastrectomy is taken, then endoscopic surveillance can be elected with total gastrectomy recommended on positive biopsy. However, we all know that a gastrectomy does carry a high risk of symptoms and poor quality of life, with the vast majority of patients being symptomatic at 12 months since the gastrectomy. And in fact, if you look at the true incidence of gastric cancer in this cohort, there is evidence that this risk is declining. So this is the quoted risk of gastric cancer according to the most recent guideline papers, and you can see that it was very high in 2010, and then it nearly halved in 2015, and it's gone down to 40% or around that according to the 2020 guidelines. So what is the reason for that? The reason is that there is an increasing population of patients that get a diagnosis of CDH1 pathogenic variant due to the commercially available multi-gene testing. And in fact, what really matters is whether they have a family history of gastric cancer or not. And you can see that these individuals with either no family history or very little family history, with only one first-degree relative with gastric cancer, have a risk which can be as low as 10–15%. And it only increased to nearly 40% in people with extensive family history. So this is really important to take into account, because if we recommend prophylactic total gastrectomy to all people with a pathogenic variant of CDH1, there is a risk of overtreatment. So this is a study that we published in 2023 where we looked at a cohort of people with family history of gastric cancer, so 145 individuals with family history of diffuse type gastric cancer, of which 2/3 had the pathogenic variant in CDH1 and 1/3 did not. You can see that upon a follow-up time overall of 51 months, about half of the people with pathogenic variant of CDH1 did have evidence of signet ring cell carcinoma on biopsies. Only about 10% of the people without mutation did have evidence of signet ring cell on biopsies. However, only 34 out of 101 in our cohort did eventually proceed to prophylactic total gastrectomy, and we'll have a look at what this means. So how do we perform endoscopic surveillance in this population? And these are the 6 things which I think are very important when embarking on endoscopic surveillance in this subgroup of people. We have to ensure that the mucosa is very clean, and we do give in Cambridge a antifoam and mucolytic drink prior to the procedure. We need to allocate a slot of about 30 minutes where we ensure accurate assessment of the mucosa. We need to assess the distensibility of the mucosa on dynamic insufflation, use magnification endoscopy for a comprehensive assessment of the background mucosa, targeted biopsies of any macroscopically abnormal area, and take random biopsies according to a protocol. In Cambridge, we use a modified Cambridge protocol, which entails 2 biopsies in the prepyloric area, 4 in the antrum, 4 in the lower body or transitional zone, 6 in the gastric body, 4 in the fundus, and 4 in the cardia. And then targeted biopsies of any visible lesions. So what are the visible lesions that you can encounter during surveillance of these people? There is a recent classification from the Dutch group, which I'm quoting here, which does reflect some of the findings that we have in the Cambridge cohort. The type 1 lesion are lesions which are typically flat, pale, non-elevated, and they generally relate to T1A signet ring cell carcinoma. Type 2 lesions generally tend to be hyperemic, elevated, more than flat, and do have a different, very abnormal mucosa on magnification endoscopy. And then we have the type 3 lesions, which are typically related to T2 or T3 stage cancer, where the mucosa is edematous and the sensibility of the stomach is reduced, and these usually correlate with infiltration of the muscularis propria. So in our cohort, these are the patients that have had evidence of signet ring cell carcinoma during their surveillance. Each line is a patient. On the x-axis, there is the time. The blue dot corresponds to their first evidence of signet ring cell carcinoma on biopsies, and the red diamond corresponds to the gastrectomy. You can see that many patients, despite having evidence of signet ring cells, did go and continue with their endoscopic surveillance, and by the end of the study period did not have prophylactic total gastrectomy. The median follow-up in this group was 22 months. 62% of the patients with SRC on biopsies were still in follow-up by the end of the study. Only one patient developed advanced cancer, and this was a patient that decided to go on with surveillance despite recommendation of total gastrectomy. And these results were replicated in a subsequent study from the NIH group, where there were 120 patients that had multiple EGDs with a similar follow-up time. In this particular cohort, 2 patients were found to have stage 2 cancer on surveillance, and in both cases that seemed to be related to delayed timely surgery. So the conclusions from this first part of my talk is that the majority of the individuals with CDH1 pathogenic variant, in fact, have early stage SRC fossa in their stomach, but very few will, on surveillance, develop clinically significant cancer. And that's because the T1A lesions seem to be indolent lesions that have a very long natural history that we are still trying to fully elucidate, but do not pose an immediate risk of clinically significant cancer. And therefore, endoscopic surveillance is an accepted strategy to de-escalate surgery, even in the presence of indolent lesions. So what are the most common lesions? In fact, we did show that the majority of the signet ring cell will be found in pale areas. We had very few positive findings in polyps, only 1, erosions, or other findings. And we recently extensively characterized a way to to predict neoplastic involvement on these pale lesions. So pale lesions are more likely to be neoplastic if they are round, if they have sharp borders, if they have irregular microvasculature on magnification endoscopy, or irregular microstructure, and are reproducible on dynamic imaging. And we gave a letter to each of these endoscopic features: A for shape, B for border, C for vessels, D for structure, E for reproducibility. And with the machine learning approach, we were able to provide a clinical decision tree. This is from the visualization of the machine learning tool, whereby we can say that if a lesion is not reproducible on dynamic imaging, so you cannot see it on white light and MBI, or it disappeared during dynamic imaging, is very unlikely to be neoplastic. So given its reproducibility, if it's diffusely irregular in terms of microvasculature, then it's very likely to be an SRC. Otherwise, you need to look at its shape, and if it's round, then assess the borders and the microvascular again to see if there are fine irregularities in the microvasculature, which would suggest an SRC. So this is being presented as a poster tomorrow, so you're welcome to have a look. So on dynamic imaging, then this is the pale layer that we would want to assess. It is round. And then on MBI, you can approach it with the magnification. This is using near focus, magnify, and then assess the microstructure and the microvasculature to decide whether this is likely an SRC or not. And this is likely an SRC because it's round, relatively sharp borders, and diffuse microvasculature. So the Cambridge criteria do have a high diagnostic accuracy for early signet ring cell carcinoma. And we developed a machine learning derived clinical decision tree to assist the endoscopists to characterize the lesion and assess the likelihood of neoplastic infiltration. So finally, how do we identify then the high-risk patients if they all have indolent SRC lesions in their stomach? How can we tell them apart from people that we think are higher risk and maybe should have surgery? And I draw a parallel with many GI conditions where the extent of the disease matter. So Barrett's esophagus, for example, longer segment have higher risk of cancer. Gastric atrophy, we learn how the extent matters. Or severe UC, which is known to have a higher risk of cancer. So perhaps this is true also in hereditary diffuse gastric cancer. So we looked at a cohort of patients that were in surveillance under our group, and then after multiple EGDs end up having gastrectomy with detailed assessment of their stomach. And we correlated the number of foci that were found under extensive examination of their stomach with the number of risk factors. And this is the multivariable analysis where we looked at, for example, the average number of positive targeted biopsies, the average number of positive random biopsies, as well as their family history, age, sex, ethnicity, and type of mutations. The only factors that actually correlated with the risk of having high burden of signet ring cell carcinoma in their gastrectomy specimen was the average number of positive random biopsies and the average number of positive targeted biopsies. We did have a little bit of signal from the ethnicity, but we think this is correlated to two large Asian families with a high number of individuals affected. And we can see here that if you look at the last two endoscopies, the number of positive random biopsies and the number of positive targeted and random biopsies highly correlated with the burden of disease on gastrectomy specimen, suggesting that it is important to keep taking the random biopsies because they do give an additional information compared to the targeted biopsies that is helpful to estimate the burden of disease in the stomach. So in conclusion from this part, we can say that the systematic, targeted, and random biopsies are essential to estimate the risk of early cancer burden in this group of patients. And that low number of SRC foci in the absence of advanced lesions indicates scarce neoplastic gastric involvement and perhaps is an indication for continuing surveillance in this subgroup of patients. So these are all the people that have contributed to the studies in Cambridge, and I'm very happy then to open this up to discussion later on.
Thank you very much. Our next speaker is Yutaka Tomozawa from the University of Washington, and he will be speaking on atypical gastric masses, GIST, NEST, and beyond.
Good afternoon. Thank you for AGA for organizing this conference. So the atypical gastric mass is very broad, so including GIST, so neoplastic and non-neoplastic mass. So in this limited time, I will focus more on the subepithelial gastric mass. Okay. My disclosures. In this talk, my goal of today is to review the gastric subepithelial mass that gastroenterologists may encounter in the clinical practice, and to understand the prognosis of each subepithelial lesions, and then try to formulate the management treatment strategies. For subepithelial lesions can be found in 1 in every 300 upper GI endoscopy, and then it's considered to be about a 2/3 located in the stomach. So for those who do not do endoscopy ultrasound, so as you can see on left image, left side images, so on the traditional echo endoscopy, which we're using, we divide the gastric layer into the 5 layer. So first, second is the mucosal layer, and then followed by third layer is the submucosa, which typically hyperechoic on echo endoscopy images, and then our fourth layer is the musculus propria, so muscle layer, which is a hypoechoic, and then followed by a fifth layer, which is in the stomach, which is the serosa. So the common subepithelial lesion, one is a pancreatic rest. It's very common. We can commonly see in a gastric antrum glider curvatures. On the endoscopy images, we often see umbilical surface, as you can see. If we apply the echo endoscopy EUS, so typically second submucosal and then third submucosal layer involvement. So statistically, very low malignant potential on the pancreatic rest. Similarly, lipoma, which is also common. So on the endoscopy view, as you can see, slightly yellowish the lesions. And then when you push the lesion by using the biopsy forceps, you can see pillow sign or cushion sign, which has been very high specificity based on the Juhar's prior studies. So when we do echo endoscopy, so EUS, typically the third layer, so submucosal layer. And then, so unless the lipoma is very large enough, and typically asymptomatic, but sometimes it can cause bleeding and obstruction. So other usually benign subepithelial lesion, schwannoma, is thought to be arise from the nervous plexuses of intestinal wall, usually gastric body, and then duplication cyst in the stomach. So more commonly in the esophagus, but we could see the duplication cyst in the stomach. So it's a very characteristic echo endoscopy images. So you can see 2 cysts, and also you could potentially recognize the 2 cystic, 2 nodular lesions on the endoscopy images. So for these lesions, subepithelial lesion in the stomach, so if the diagnosis is clear, and so typically we do not, for a diagnosis clear and also asymptomatic, and we typically do not recommend surveillance or endoscopy or echo endoscopy. There's a question for lipoma. So if we see a large lipoma, especially, there's some question whether there's some component of liposarcoma, or if the lipoma is growing larger, it could be potentially progress to liposarcoma. But we don't have enough data to justify we should do surveillance for lipoma as of now. So in general, we recommend EUS for subepithelial lesion in the stomach to characterize the features, size, location, shape, and then more important, where is the which layer is the originating layer for the subepithelial lesions. Especially for gastrointestinal stromal tumor, GIST, and 2 centimeter or larger one, we typically need tissue diagnosis by doing EUS guided fine needle biopsies. And so if the FNB is non-diagnostic or the lesion is smaller than 2 centimeter, so there is the technique we call the mucosal incision-assisted biopsy to confirm the diagnosis. So on the top one is a gastric gist on the middle images. So the gist is originating from the fourth layer, muscle layer, which is a hypoechoic layer. And then on the right one is the fine needle biopsy by ultrasound, endoscopy ultrasound. So the below one is the mucosal incision-assisted biopsy. So we usually use the electrocoating knife, which we typically use for endoscopy, mucosal dissection, ESD. So we cut the mucosa and then dissect some mucosa and then try to expose the lesion and then grab the tissue by doing forceps biopsy. So which has been shown to be safe and then high diagnostic yield. But I think only one downside or maybe one limitation for the therapeutic gastroenterologist side, if we want to do the resection by endoscopy after diagnosis confirmed, this submucosal dissection and then biopsy could cause some mucosal fibrosis. So sometimes therapeutic endoscopy don't like by doing diagnosis because a subsequent the endoscopy resection can be challenging. So gist is commonly seen in the stomach, and so often seen CD117 antigen expression, which is actually usually negative in leiomyoma, leiomyosarcoma, so it can be diagnostic for gastric GIST. Gist. So CD117 is the synonymous with the transmembrane KIT receptor tyrosine kinase. And then other molecular marker would be tyrosine kinase platelet-derived growth factor receptor alpha, so PDGFRA. So these two are mutually exclusive oncogenic mutation in the gastric gist. And so the PDGFRA mutation are more likely to occur in the gist that lacks the KIT expression. And then PDGFRA mutation are more commonly arise in the stomach and then present with a more indolent disease. So I think as the gastroenterologist, when we see the pathology report with the expression, then we can see the patient the prognosis. And so majority are sporadic, the gastric gist, but about a 5% can be considered in genetic syndrome. So when we see the early onset or multiple primary site in the stomach, can be in the familial gist syndrome. I think it's rare, but can happen. You may encounter in this case in a clinical practice. Or the patient with the neurofibromatosis type 1 tend to have the gist and more commonly in the gastric gist. So, but usually incidental finding and asymptomatic. But if the gist is the larger, and so it could cause a GI bleeding or some pain or obstructive symptoms. So specifically gastric gist is the size is 2 centimeter is the usual cutoff for prognostication. As you can see, the NCCN guideline, the most updated one, 2025. So still based on the available data, so 2 centimeter or smaller gastric gist is very low risk metastasis. So it's a good prognosis. So the just 2 centimeter or smaller, and especially non-high risk EOS features, then currently we recommend surveillance. But as the endoscopy modality is advancing, so we have some technique and approach to actually remove endoscopy removal for this smaller gist. But we still don't have any good evidence if the resection is better than surveillance as of now. So the 2 centimeter or larger one, so more larger than 2 centimeter, I think we should discuss the multidisciplinary conference with the medical oncologist, surgical oncologist, and then we should remove the gastric gist. So as I briefly mentioned, so endoscopy modality is available. So to speak, some mucosal tunneling endoscopy resection, SDER, or like usually size limitation up to about a 4 centimeter or so. But if the larger one, we call it exposed, endoscopy full thickness resection, which means endoscopy by doing endoscopic, full thickness resection, and then we close the transmural defect in the stomach by a combination of the suturing and or clipping. These endoscopy technique, recent meta-analysis comparing endoscopy resection versus laparoscopic resection, which is considered to be standard resection modality as of now. So as we would expect, higher rate of the positive margin in endoscopy resection than laparoscopic resection, but oncologic outcome, meaning complication, recurrence, 5-year disease-free survival, it's a no difference based on a meta-analysis. But still, we do not have any, great, data to suggest endoscopy therapy is comparable or better than laparoscopic resection. So, neuroendocrine tumor. So, as you know, gastric neuroendocrine tumor is a type 1, 2, 3. So, type 1 and 2 are associated with the hypergastrinemia. So, in type 1, it's about 75 to 80%. In response to atrophic gastritis, and type 2 is about 5%. So the type 1 and 2 are both usually clinically indolent, and so both are low-rate metastasis. So as of now, based on our NCCN guideline, so if the lesion is larger than 1 centimeter, endoscopic resection be recommended. And then in type 2, if there's some primary pancreatic, the gastrin-producing tumor, then we should also treat or manage the primary tumor as well. And type 3 is the sporadic tumor, and that develop without hypergastrinemia, and so behave more aggressively than type 1, type 2. So our current recommendation is if there's no regional lymph node in metastasis, we should consider resection surgically or endoscopically. So how about endoscopy resection for gastric neuroendocrine tumor? So things sometimes depend on the size, expected depth of invasion, location matter for our therapeutic gastric endoscopy assessment. But if the lesion is small, so 1 centimeter or smaller, whether type 1, 2, or 3, if we apply the endoscopy submucosal dissection so we have more negative margin for resection as compared to the conventional endoscopic mucosal resection. But when we look at the recurrence or metastasis after endoscopic resection, so especially type 1 or type 2, still limited evidence or limited literature, but data suggests type 1, type 2, there's no clear advantage or no recurrence even after positive margin resection, whether EMR or ESD. But type 3, I think because of the higher risk of the metastasis or more aggressive oncologic behavior, so I think we favor ESD, so endoscopic submucosal dissection, to aim at the margin negative, complete endoscopic resection. So this is a patient who referred to me for management of gastric neuroendocrine tumor 3 months ago. So patient in his 60, white Caucasian male who had a long-standing, who's obese and who had a long-standing GERD symptom. So who actually had initial upper endoscopy for like a GERD assessment, screening part the esophagus, and then so the outside gastroenterologist found some gastric polyp, and then they did a biopsy. And then pathology came back neuroendocrine tumor. So they referred to me for management. When I did the endoscopy on above 2, so antrum gastric body, so I clearly did not see any macroscopic evidence gastric atrophy or no multiple gastric ulcers. So I thought, unlikely type 1 or type 2, maybe type 3. And then so I recognized at least 5 polyps in the gastric body, and which seems to me as all like a neuroendocrine tumor. So I was not sure this was the type 3 or type 1. For both diagnostic therapeutic extent, so I achieved the endoscopic mucosal resection for all of recognized gastric polyp. And then pathology all came back as the well-differentiated neuroendocrine tumor. But when you look at the WHO grade as a grade 2, all of them, and then also Ki-67 index is slightly higher than I would expect in type 1. But pathology, when I asked the pathologist, pathology did not see any evidence of background gastric atrophy or intestinal metaplasia. So clearly, it does not look like type 1 or type 2. Could be type 3. So I talked to my colleague, medical oncologist, and then he thinks that this will be the other type of neuroendocrine tumor, which is a type 4. So it's a more recent defined type, a type 4 gastric neuroendocrine tumor, so which is no background of atrophic gastritis, and typically polypoid lesion anywhere in the stomach. And then it's considered to be a rise in a moderate hypergastrinemia in patients who are treated with a very long-standing high-dose PPI. And so very limited literature yet, but it looks like apparently it's some different clinical characteristics than type 3 or type 1, but it looks like a better prognosis type 3. So I think we need a little bit more data to formulate a treatment plan for the type 4 gastric neuroendocrine tumor. So summary in my talk today, so atypical gastric mass. So if the cushion sign, pillow sign is positive, it's likely this is a lipoma. And otherwise, pancreatic rest, schwannoma, duplication cyst, we typically can diagnose endoscopy or ultrasound and without needing any EUS biopsy. So just less than 2 centimeter, whether surveillance or resection, but there's no good data say resection is better or comparable than surveillance in terms of oncologic outcome. So GIST is the 2 centimeter larger one. We should communicate with the multidisciplinary conference. If they're deemed resectable, we should resect, and so possible adjuvant therapy based on the immunohistochemical finding. If the endoscopy therapy or surgical resection, but again, there's and then so either surgical or endoscopy. So type 1 and 2, type 2 neuroendocrine tumor, so resect if larger than 1 centimeter. I think type 1, type 2, I think still EMR is likely favorable because of the low rate metastasis, indolent nature in general. But ESD can be done in selective case. So type 3, again, multidisciplinary conference, so resect if deemed resectable. And so ESD can be a modality to aim at the negative margin unblock complete resection. Thank you.
So we move on for the last speaker, Marco Lenti from Padua. He will speak us about an enigma. It's a fact or a fiction, the precancerous autoimmune gastritis.
So first of all, good afternoon to everyone, and let me thank the AGA for the kind invitation. You left the very hardest bit in the end of the presentation, so hopefully I will make a sense out of what we know about the risk of developing cancer in patients with autoimmune gastritis. So this is my presentation agenda. First, we're going to talk about this disorder. And then what do we know about the basis of gastric cancers in AG? What is the available evidence about the natural history of AG? And what do recently available guidelines suggest in this regard? So first of all, what do we talk about when we talk about autoimmune gastritis? This might seem a silly question, but actually is not, because most of the available knowledge we had until a few years ago actually was based on the assumption that autoimmune gastritis was either a condition affecting the corpus fundus of the stomach, which is actually autoimmune gastritis, or also pangastritis, which is something different. So when we talk about AIG, we're talking about an organ-specific autoimmune disorder which only affects the fundus corpus mucosa of the stomach. And it is also characterized by the inconstant presence of autoantibodies, which may be or may not be present. In fact, up to 20% of the patients actually have no autoantibodies. Indeed, this needs a proper diagnosis must be based on the Sidney-Houston protocol, so at least 5 biopsies. And Rugge et al. Has recently revisited the current gastritis classification with the regain consensus by adding a few more insights into the diagnosis, pathogenesis, and prognosis, but we will see these later on. Indeed, autoimmune gastritis is a very complex pathogenesis. We know that the etiology is unknown. We know that the major autoantigen is the HK ATPase. We know that there is a massive infiltration of CD4 positive lymphocytes, which are much more represented than CD8 cells. We know that there is a plethora of pro-inflammatory cytokines within the mucosa. And we know that there are several microbiota alterations. Indeed, the pathogenesis of the development of neuroendocrine neoplasias or epithelial cancer depends on the type, the extent, as already other speakers said before, of the lesions. And there are also several additional factors, exogenous and endogenous factors, that play a role in the development of cancer. Specifically for neuroendocrine tumors, we know that gastrin is a risk factor, so the level of gastrin correlates with the risk of developing this form of cancer, because it exerts a proliferative effect on both G cells and possibly also on epithelial cells. And indeed, we know that ECL dysplasia is a clear risk factor. But when talking about the factors increasing the risk of developing cancer in these patients, we might divide them into known autoimmune gastritis factors like age, sex, ethnicity, as Shaila talked about before, the geographical area, which is very important, comorbidities, and so on. But which are the age-related factors? We have the diagnostic delay, which often is very high in these patients. We have the severity of atrophy and metaplasia that must be taken into account. We must know about the history of H. pylori in these patients and the concurrent presence of atrophy in the antrum, which again is not an immune gastritis, but that is something different. And this has also been nicely summarized by Rugge, where he highlighted the fact that the risk of progression of premalignant gastric lesion differs depending on the previous or the active presence of H. pylori, the extent and the severity of the lesions. And also, it depends on various host environmental factors. We have already talked about this, so I'm going fast on this and this other slide, which has already been presented. Basically, to summarize these, we know that the higher is the degree of the lesions and the higher is the probability to develop cancer. So we have the highest degree with dysplasia and the lowest one basically with the presence of gastritis, so the chronic inflammatory disorder, or just with atrophy. But which were the limits of these big studies or meta-analysis? Well, first, the extension and severity were not taken into account. The type of gastritis was not taken into account. And the presence of H. pylori was not stratified in these studies. So basically, and also please note that this study enrolled patients from 1979 when H. pylori was not even known. So basically, we carried on over time this assumption that AIG actually was a risk factor of cancer for this reason. But very recently, it was published here in the US by the group of Richard DePaulo, a very interesting study where he found that both H. pylori infection and autoimmune gastritis may increase the risk of developing this type of cell, which is an AMP positive CD13 cell, which has been also found to be highly prevalent in patients with esophageal cancer and also other GI cancers. And this happened in both types of gastritis. So this is not a signature of either one or the other type of gastritis. So we do have some biological basis to think that AG might be a risk factor for cancer. And what do we know about the natural history? Over the last, I would say, 5 years, several studies on the natural history of autoimmune gastritis has been released. One by Rugge, where he included only pure IG patients, and by pure I mean that H. pylori was always excluded rigorously, not only on the basis of the stool antigen test and the biopsy, but also with other molecular analysis. Basically, he found no cases of gastric cancer. This is our study, and we basically found we had similar results, but on a longer time span. We enrolled here patients for more than 20 years, and we only found a few patients developing low-grade or high-grade dysplasia, but none of them had invasive gastric cancer. But our conclusion was not that AG is not a risk factor for cancer, but actually by applying the surveillance, the proper surveillance, and by removing dysplasia, and by treating patients, we actually decrease this risk to zero. But the important thing is that when we consider multi-center studies, when also patients who had previous H. pylori, or maybe also patients who had atrophic pangastritis, so a less selected population, actually cancer was present. And here we had 15 cases, for example. Similar results was also found by the group of Professor Lanner in Rome. And as you can see here, the risk of developing T1 neuroendocrine tumors, in this case, was the presence of pernicious anemia, as well as for high-grade lesions of gastric cancers. What does this mean? It means that pernicious anemia usually takes up to 20 years to become evident. So this means that those patients were those who were neglected and were not, and who were not previously diagnosed, and then they went missing to the follow-up. Again, this is another multi-center study. So again, when we include more heterogeneous populations, we see that the risk of cancer actually exists. And in this case, it was, you can see we had 29 adenomatous lesions, 13 cases of adenocarcinomas, and also 1 case of lymphoma. And indeed, I did not focus on neuroendocrine neoplasm because we know that in this case, we have a lot of evidence about this. And autoimmune gastritis. Oh, another important thing is that there were no difference with the Olga stages, Olgim stages, and in patients who developed cancer. Why? But well, the answer is simple, because the worst IG patient will always have a stage 2 Olga, no more than that. So Olga and Olgim are completely useless in autoimmune gastritis for stratifying the risk, because the maximum is 2, okay? And then here, I wanted to show you the result of this interesting study, where we included 4 Italian institutions, and we enrolled 26 patients with AG who actually had cancer. And what we found is that most of them had a very low stage, PT1, and only 4 cases, gastric cancer was diagnosed at follow-up of IG, while all the others were in the context of a previously undiagnosed autoimmune gastritis. So again, if you neglect the disease, then you might miss the cancer. What about guidelines? So given all these uncertainties, actually, we were not surprised that just, I think, like 5 days apart, one guideline was released from the other, 5-10 days apart. According to the ACG, there is not enough evidence to make a formal recommendation of the endoscopic surveillance in IG. While according to the Europeans, differently to the MAPS-2, this was the endoscopic follow-up, which was every 3 to 5 years. Now they recommend 3 years. According to the opinion of a few people who signed this letter, which is not online, but you will find it soon, next week, basically what we think is that probably the 3 to 5 years was still acceptable. But anyway, this is just our idea, and I think that this is ground for a huge discussion. Going back to the question, is that a fact or fiction? Cancerous modifications actually occur in some epithelial cells, and this is a fact. The most recent evidence shows that the risk of developing overt adenocarcinoma in pure IG, but in tertiary referral centers, is low or nearly absent. But why? Because we do follow the guidelines, and we endoscope our patients, and we remove dysplasia. So this likely reflects the efficacy of these. While when we include more heterogeneous populations or previously undiagnosed patients, then we see cancer much more. AG certainly predisposes to the development of type 1 neuroendocrine neoplasias, and there is no doubt about this. And future studies basically should better define the true risk of developing carcinoma through prospective long-term studies for better patient stratification. Let me thank, in the end, all the people who have been working on this. So our Italian group, this is the city where I work in, Pavia, which is a medieval town in north of Italy. This is Florence and Rome. These are the places where we usually meet. And also like to find the international study group, where you can see many people from around the world. So if you want to join, just drop an email. I will be very happy. And we're studying all these issues, and more data are soon to be released. Thank you very much.
So, any question from the audience? We are 1 minute away from the end, but I think we can accept 1 or 2 questions.
Very quickly and very simply, I'm Beth Shore-Lesnick, Westchester Medical Center in New York. Just wanted to know, how many jars do you get when you're sampling, doing random biopsies for gastric metaplasia surveillance? Do you combine jars from the antrum and angularis and separate them into and then have a second jar for the proximal stomach, or do you do separate jars? You know, and the other, do you do separate jars, greater curvature, lesser curvature, antrum, angularis, greater curvature, lesser curvature? Proximal stomach.
I kind of want to, that's a great question. I want to rephrase that for Greg. How do you want us to give you the specimens?
Well, at least 2 jars is helpful. One corpus mucosa and antral mucosa.
Which combines the greater curvature and lesser curvature from each one. So you don't need to have the 5 jars.
Well, here's the thing. So in general, you at least to take 2 jars. So one from antrum, incisura, one from corpus. But if you see something additional, for example, you see multiple areas of GIM, you should take more biopsies, just because otherwise you can, if you take random biopsy, non-target, you can miss GIM because it's really patchy. You have to just look for GIMs, either with MBI or SAI.
Thank you.
I want to follow that up again for Greg, because you mentioned that more tissue is better. Is Sydney protocol sufficient, or do pathologists want more tissue?
No, I think that, well, if we want to do the whole jar or whole gym, if it's something that you would like to do, the more biopsies, at least the 5 biopsy protocol is good enough. I know that there is a lot of discussion now whether or not we need a biopsy of the incisura or not, but then any additional tissue, just to follow my colleague, is any area of irregularity, because when we get the biopsy, we get the phone calls. Where is the dysplasia from? I don't know. So obviously we need, for the sampling and the mapping, we need at least 2. And then for any irregular lesion or any mucosal irregularity, another jar.
And 2 is all you need to determine resection, where you're going to resect if you have advanced disease, right? I mean, distal gastrectomy or proximal gastrectomy, right? I mean, you don't need to know that it comes from the greater or lesser curvature.
Yeah,
is that right?
Just 2 points. One, don't forget endoscopy. Okay, don't focus too much on the number of biopsies. Please clean the mucosa, see the best you can, and when we speak about removal, do not remove intestinal metaplasia. It's about dysplasia. Okay, so if you detect intestinal metaplasia, it's not to send that patient for surgery, please.
No, that's not
okay.
what I meant. I meant dysplasia. Yeah.
Okay.
Yeah.
Mario, can I throw a little stone in the pond? So if a patient, especially in a country or in a place where olga-olgimas are not used, if you have a patient with known GIM who is under surveillance, is there actually a role for Sydney protocol biopsies, or should we actually focus only on targeted biopsies?
Thank you a lot. So according to the new, so it's, of course, we are a Western Eastern table here. And if we ask the Japanese in the audience, they do not do biopsies. They look to atrophy and intestinal metaplasia with their eyes, because we are morphologists as good as pathologists if we want to stage atrophic. So this question is very important. Once you have your patient eradicated for H. pylori and under surveillance, you do not need more biopsies, because in principle you will not face regression, and you just need to look for not missing a cancer. So take your time to look for the cancer. Thank you, Matthew.
One more comment.
And yes, you may target biopsies towards the sites where you recognize intestinal metaplasia, but for that you need to, have scores and have
Just
training.
quick comment. So eradication H. pylori is not done yet. So in the East, we're seeing the gastric cancer even after H. pylori eradication. So just be aware, eradication H. pylori is not done yet to screen or to detect early gastric cancer. So.
Do I have great talks, everyone, for Yale University of Chicago? Do I have time for one or two questions? Two? Okay. So one for Dr. DiPietro. In your research, you follow patients who do not have CDH1 but have what we call HGGC-like phenotype that also sometimes have signet ring cells identified on their random biopsies. My question is, do you think do they have the same biology? Do they behave the same as CDH1 patients? Are they affected by something environmental that we just don't know of? Are they affected by H. pylori? Because we also see these individuals with multiple family members with gastric cancer who we sometimes identify the H. pylori in one of the family members. It's sometimes difficult to tell if it's intestinal type or diffuse type, and we're sometimes stuck when we want to consult them and tell them what we should do next and how often we should have endoscopies, and how do you usually deal with those kind of families?
So in our original study, in fact, these people had not been tested for alpha-catenin, so we are actually retesting them to establish who of them had actually CTNA1 mutation. But if you have a patient with CDH1 negative and CTNA1 negative, then they definitely are at lower risk. So these patients were followed up equally as the CDH1 positive, but now we are prolonging the intervals to 3 and 5 years because we do believe that they are at much lower risk. Those 5 out of 50 that did have SRC, they seem to have the same type of lesions as in the CDH1 positive, and probably because some of them did have a genetic predisposition that we do not understand yet.
And my second question for the entire group, you brought up what to do when there's no Olga and Olgim that are being given to us by the pathologist, or know whether or not this is complete or incomplete. What do you do with the patients when you need to stratify these individuals? Do we actually need to continue follow up with them, or it might be low risk if there's because if I find a small area of intestinal metaplasia only in the antrum, not in the body, and I don't know if it's a high-grade Olgim or if it is incomplete histology, what do I do with the patient? I usually tell them, come back in 3 years, I'll continue to follow up on you. But is there what should we tell our patients until we get the Olga and Olgim?
Yeah, I think it certainly is a challenge in terms of, especially in the United States, hopefully it will change soon, that it really does require coordinated GI and pathology discussion and moving that forward. It's going to take time. But really, again, like we've said, really focusing on your endoscopy. And so if you are confident with your exam that there truly is only a very focal area of intestinal metaplasia in the antrum, individual has no other risk factors, no family history, they're eradicated of H. pylori, then that individual might not warrant ongoing endoscopic surveillance. And so really just leveraging also your endoscopic skills.
Yeah, and just take care that focal site is not very close to the pylorus, because this is what probably the prevalence or the differences in prevalence are all about. Because if we truly measure the people at risk, they are a small amount or a small proportion of the patients that we attend. Those patients, the majority of patients, will not have the need for surveillance. Okay.
I want to just ask one final question because I think this is the most important because Shalja's up here. Yes, this is the opportunity. So the ACG guidelines came out and they're they're inconsistent with everybody else, right? They didn't make a recommendation on screening high-risk patients, although they then went on said GIM is high risk and then you have to survey them, right? So there's discordance. And it's inconsistent with their Barrett's guidelines as well. Barrett's guidelines, they say there's no data to support screening, but yet they recommend screening because they think it's going to work, right? So how can we correct this? How do we change the ACG?
Yeah. No, and this is we're on live TV. But it's being recorded. So I'm gonna, be a martyr on this. But it was truly a challenge because yes, absolutely there is discrepancy between the AGA and ACG, and we do have compelling evidence that there are high risk populations that would benefit from endoscopic screening, assuming that we can actually detect those high risk lesions. But through the formal grade process, there was a ton of pushback in terms of saying that we suggest, like a conditional recommendation, we do suggest for endoscopic screening in high-risk populations. And honestly, it did feel like we were punished a little bit because of the Barrett's guidelines, that there was concern that that was not the right move, and so that if there's over-screening, over surveillance and that aspect, because as it is certainly true that the majority of individuals with intestinal metaplasia are going to be low risk, and so it really was trying not to overburden the endoscopic system. But we do all know and agree that, again, kind of the title of the talk, that we really do need to act now and recognize those high risk individuals and really generate our own evidence to suggest and still move forward with teaching high-quality endoscopy for U.S. providers and still advocating and detecting those, but there's still work to be done in terms of getting it into actual guideline recommendations, I'd say.
Yeah, just a note. Well, we need to finish, and just a note because probably some of the answers may come also from to define what is a high-risk population, if it is by the setting or by the country. And we hope that in a few years we will have results from a multi-center study run in Europe where several strategies are being evaluated, even for non-invasive screening. That probably is the answer preferred by, most citizens, even for the colon. So thank you all for attending. Thank you for the speakers. Sorry for not having more time for questions, but we will be here, and just the emails are probably shared by the system. Thank you.
Thank you for staying.